रिकॉर्डिंग शुरू कर दी तूने?
वो मैंने सेटिंग जैसे कर दी कि ऑटोमेटिकली जैसे मीटिंग स्टार्ट हो ऑन हो जाए रिकॉर्डिंग।
To body shaming. Now, obesity most commonly defined by the BMI, but there are debates of how to define it. I will not go into all that, neither in the treatment, but I will just be briefing upon what all obesity or adiposity can cause and the plausible hypothesis by which it may damage our body. Now, we must understand that 40 to 70% of the contribution of obesity is from our genetic makeup. And this is one excuse that most of us use for putting on weight. We must understand that we all have a loaded gun and we are hell bent on pointing the gun at our own selves and firing it continuously. Meaning, thereby, that we know that we have tendency to put on weight and still we are not behaving ourselves in terms of diet, in terms of exercise. So, we have genetic makeup, but we should do all this. Now, biologically, brain controls the eating behavior and appetite, the hypothalamus, the area postrema, and of course, the nucleus tractus solitarius. There are few sites which actually are the ones which influence our appetite. The hormones, leptin suppresses the appetite, and GH-ghrelin from the stomach increases the appetite. Psychologically, well, stress causes increased appetite because possibly cortisol is released, and there is enough data to prove that tasty food is a very good stress buster. So, do an example that if someone is stressed, offer him bland salad and he'll hit you. And offer him some pizzas or pakoras or samosas, he'll hug you. So that is the power of tasty food. And the only two ways in which you can make it tasty is either by adding excess sugar or excess fat. On a lighter note, if you have halwa with very little oil and very little sugar, the comment would be khasa vahiyat bana hai. So the only way to make food tasty is increase the fat or the sugar content. As regards social equality, well, there's a particular food chain which I would not wish to name here, but that is the one where most of us celebrates our kids' birthday parties, while in the country of its origin, it is a restaurant wherein only the lower social class would go. I'm not here to mention names. And of course, environmentally, unhealthy eating patterns and life of sedentary. So, what we've done is we've copied the eating habits of our ancestors, but we have not copied their hard work. The, the fact of the matter is that corporates work hard, party hard. So, they are working hard mentally, no doubt, but they are hardly burning any calories. And after that so-called hard work, they party hard and have soft drinks, eat junks, beers, beer belly we all know about. However, one must understand that there are certain drugs which actually also increase weight. From the diabetes side, we know about insulin, we know about sulfonylureas, we know about glitazones. They are the ones that increase weight. And drug for neuropathy, pregabalin, prescribed so commonly that also increases the weight. So many paths can lead to obesity. It's a complex interplay, but it impairs health, increases risk of complications, and as a result, reduces. So obesity is linked to around 229 adverse conditions that a body may encompass. And these are the ones which are shown very strong evidence in dark blue, so on and so forth. And the size of circle tells us the body of evidence that we have. So, metabolic, first of all, cancers, cancer of the endometrium, CA colon, CA breast, CA stomach are all linked. NAFLD, now at the time of the publication of this paper, MASLD or MASH or MAFLD term was not coined, and since most papers are before that, so in my talk I will be calling it NAFLD rather than MASLD. So metabolically, you have NAFLD, you may have cholelithiasis, gout, because we know that insulin resistance causes hyperuricemia as well, and that, if untreated, may actually precipitate gout. Then, of course, pre-diabetes. Now, pre-diabetes and diabetes are both chronic inflammatory states, and therefore, because of PAI deficiency, may actually predispose a patient to thrombosis. Commonly, there is PCO because of insulin resistance that may cause infertility. And of course, you have insulin resistance, therefore hypertension, you have type 2 diabetes, you have dyslipidemia, and the recipe is complete for a vascular event, maybe cardiovascular or a cerebrovascular. Well, mechanical, so you have asthma because of the decreased compliance of the chest wall, you have knee osteoarthritis, you have decreased physical functioning, load on the spine, so you have chronic backache, and sometimes incontinence. And of course, on the psychological part, depression and anxiety are common in diabetes. So the risk of diabetes increases with higher BMI. In patients with obesity and pre-diabetes, weight loss reduces the risk of type 2 diabetes. Now, multiple factors, the glycemic control, hypertension, lipids, insulin resistance, and insulin dysfunction, all of them contribute to high CV risk, and weight loss seems to reduce the risk of cardiac events. HFpEF, which means diastolic dysfunction, essentially improves with significant weight loss, and also there's reduction in the left ventricular mass, and left ventricular mass we know is a surrogate marker for CAD. Now, if you reduce weight, you actually reduce the mechanical burden on the knee, and therefore the risk of osteoarthritis could go down. NAFLD, so you know that if more than 5% of fat is there in the liver, you get MASLD or NAFLD, and if you lose weight, the fat is washed out from the liver, and actually there may be improvement. So the obese and the risk of diabetes. So as compared to non-overweight patients, if a patient is overweight or is obese, there is more than twofold risk of getting diabetes, and I'll show in the graph how things turn out. With every 1 unit, which means 1 kilometer square of increase, the risk of being diabetic patient increases by 1.5%, and in the non-overweight category, increased by 0.5%. Now, how does obesity contribute? So there is an increase in the white adipose tissue, which is the sanctuary for secretion of inflammatory cytokines, the TNF alpha and the interleukin 6. They cause chronic inflammation, insulin resistance, which coupled with secretory defect causes hyperglycemia and diabetes. And what does all this cause? It causes endothelial dysfunction, formation of plaque, thrombosis, possible rupture of plaque. Now, taking a slight detour, we are also talking these days about endocrine disruptors, microplastic being one of them, and it has been shown that if the microplastic content of the atheroma is high, there is a high chance of plaque rupture. Now, because of the insulin resistance at all metabolic levels, there is increase in the activity of lipoprotein lipase, which means free fatty acids are high. They cause lipotoxicity. There is resistance to insulin. There is hyperinsulinemia, which causes hyperglycemia and decreased glucose transport because of the dysfunction of insulin receptor substrate. Also, because of the increased activity, there's increased lipolysis and there is dyslipidemia. Now, through this graph, I'll be showing how things progress. So initially, it's almost a straight line, but approximately 6 years prior to diagnosis of diabetes, the post-load glucose begins to rise. Also, there is some kind of a trajectory of the fasting glucose showing its increase. At this point in time, the insulin resistance is not that high, although the surgery seems to be going with time, but beta cell function is still preserved. Now, what happens in the next 2 or 3 years? The postprandial glucose rises further. There is still an increase in the fasting sugars. The beta cell function now increases, trying to compensate for the insulin resistance. However, even at this stage, there is a possibility of going back to the non-diabetic state because the beta cell function is on the rise. However, subsequently, there is a steep decline in insulin secretion, the beta cell function, and the postprandial sugars just hit the roof. Now, as regards hypertension, there is increased BP with increased weight. For every 4.5 kilograms, there is a high systolic BP by 4 mercury. Now, in obesity, there is insulin resistance. So what does this do? First of all, the hydrogen lithium pump at the RBC causes problems. Because of insulin resistance, there is endothelial dysfunction, which means there is decreased nitric oxide, which means that there is decreased relaxation of the blood vessels, vasoconstriction, and there is increased BP. Also, there may be plaques in the renal arteries, which may cause decreased renal perfusion, which again can amount to increased blood pressure. As regards dyslipidemia, the higher BMI is linked directly to high TG levels and inversely to HDL, which means that if the BMI rises, the HDL falls and the TG rises. So what happens therein? If there is a high TG, you will have a high propensity of small dense LDL particles, which we know are highly atherogenic, and risk of CAD increases even at normal LDL levels. And also the level of HDL goes down. HDL we know is a scavenger molecule. HDL we know is a negative risk factor for CAD. So on the one hand, you have small dense particles which are high risk. At the other hand, you have low HDL, which means low protection, and therefore you have a complete scenario to favor CAD. So obesity and CAD, around 10 kg gain in body weight increases risk of CAD by 12%, and therefore higher is the BMI, sooner is the chance of a coronary event happening. Also, 1 unit increase in BMI, the increased risk of hemorrhagic stroke by 6% and ischemic stroke by 4%. So you have increased risk of CAD, increased risk of cerebrovascular disease as well. So obesity or CVD, you know that across the spectrum, so you have normal weight, overweight, obese grade 1, grade 2, the risk of CAD increases accordingly. 18% rise in men, 34% in women. We know that women, till the time they are far from menopause, are protected against CAD. But if they develop type 2 diabetes, then this gender-based advantage to the fairer sex is lost. So just to recapitulate again, why does CVD happen? Of course, the blood pressure is high because of the various reasons I've told before. Blood glucose, so you know that because of high blood sugar levels, there is increase in the microvascular as well as the macrovascular complications. Insulin resistance decreases the compliance of the blood vessels, and so there may be decreased perfusion, and there may also be an increased resistance and blood pressure. The lipids, we've talked about the HDL, we've talked about triglycerides. Inflammation, so diabetes, inflammatory disease, or obesity rather. When we talk about inflammatory, we don't mean the typical rubor, color, dallor, and the loss of function. No, what we actually mean is inflammation with the inflammatory cytokines like the interleukin 6, the TNF alpha, the vaspins, and the resistance, which work over time to increase the risk for diseases. Also, there's an increase in the expression of ICAM and VCAM, the adhesion molecules. There's foam cell formation, smooth cell proliferation, particularly in the carotids. Pyridazone is one agent which actually reduces the risk of CVD, and it does so by reducing the CIMT, the carotid intermedia thickness, and also reducing the smooth muscle proliferation. Fatty material in plaques, I've talked about in detail earlier, how they rupture, and also some endocrine disruptors, if present, can hasten the rupture. So if they rupture, there is thrombosis, and depending upon the blood vessel, they could cause an MI, a stroke, a renal infarction, so on and so forth. Now, when we used to see the report of echocardiography, we used to feel, अरे इनका क्या है, ये तो हर report में लिखते हैं diastolic dysfunction. But actually, it exists. The elephant was always in the room. That we chose to ignore it is a different matter. But with the advent of gliflozins, we actually found that diastolic dysfunction may actually be reduced. Now, with increased BMI, there's a risk of HFpEF by 34% and HFrEF by 18%. Waist circumference, again, a similar risk. As I said, waist circumference in Indian females less than 80 centimeters, in males less than 90 centimeters. The BMI in Indians up till 22.9 is okay. It is not the same as the Western counterparts. So 23 to 24.9 is overweight, and more than 24.9, which is 25 and above, is actually obesity as far as the Southeast Asians are concerned. So how does HFpEF happen? Well, obesity, there is increase in leptin because of leptin resistance. They increase the renin-aldosterone activation, decrease in BNP. Now, some of us may actually feel that in cardiac failure, there's increased BNP. So if the BNP levels are low, it is beneficial. No, that is not the case. BNP, friends, one must understand, is a natural neprisilin inhibitor. With high BNP, you have cardiac failure? No, that's a paradox. The paradox is that there is resistance to BNP in patients with cardiac failure. Something like insulin resistance, like if someone is obese, high insulin levels are not good. On a similar note, there is resistance of BNP to the myocardium, and that is why the BNP levels are high in cardiac patients. So all of this culminates in increased plasma volume, increased sodium levels because of the RA activation, inflammation, and this aldosterone also leads to fibrosis of various organs, the cardiac, the renal, and that is why we were doing everything to reduce the renal issues, proteinuria. We were giving ACEs, we are giving ARBs, and now giving the gliflozins, possibly GLP-1. But there was this some element which actually remained, and that is possibly being tackled by finerenone, the process. We've lot known that aldosterone may cause cardiac remodeling, and we did have aldactone and eplerenone for that. But finerenone has emerged in a big way to tackle the renal fibrosis component contributing to proteinuria. Also, as I talked about, there is decreased chest wall compliance in patients with obesity. So there is increased LV stiffness, there is decreased filling pressure, increased filling pressure, and of course, the HFpEF is there. The mechanical ones, osteoarthritis, strong correlation with overweight, obesity, were approximately 2.5 and 4.6 times likely to have risk of osteoarthritis as compared to patients with overweight. And if you look at your right, up till maybe 25, everything is fine. And then as the BMI crosses 27, the thing just shoots up. So, well, pathogenesis. So to your left is the normal knee anatomy, and to your right is the one with osteoarthritis. So with weight gain, there is meta-inflammation, and cytokines cause inflammation. They affect the cartilage integrity. As a result, there is bone remodeling, there is bone sclerosis, breakdown of cartilages, synovitis, osteophytosis, and as a result of all this increased loading, there's increased risk of osteoarthritis. Now, patients with obesity are increased risk of developing NASH. We all know that. Again, MAFLD or MASLD. The reason is fatty liver, then steatohepatitis, then fibrosis, then cirrhosis, and possibly risk of hepatocellular carcinoma. So obesity is the driver for NAFLD. 80% of patients with obesity have NAFLD. Obesity, 3.5 times risk of increasing NAFLD, and therefore there may be association with NAFLD and waist circumference. So fatty liver. So fatty liver can actually be a predecessor of type 2 diabetes and also CVS and cancer of the liver. So this is
Dr. Dheeraj, please unmute yourself.
So this is my last slide. So we have all heard about obesity and the Medusa paradox. I'll talk about someone closer home, that is obesity and the Ravan paradox. So we know that the demon Ravan had 10 heads, and every time Bhagwan Sri Ram would sever one head, the next would emerge. So that is the paradox, that if you keep on addressing all the morbidities one by one, you will reach nowhere. So what did Bhagwan Ram do? He just fired one at the navel, the Amrit was busted, and Ravan was gone. So you have to fire at the obesity, and the moment you fire at obesity, which means you lose weight by diet, by exercise, possibly by medications, you chop one by one hypertension, MASLD, type 2 diabetes, PCO, arthritis, CVD, NASH, so on and so forth. So, to conclude, a weight-centric approach in chronic diseases should lead to a wide variety of health benefits rather than traditional approach of just focusing on complications, which is downstream. Let us focus upstream. So, obesity is a gateway disease to the complications. Improvement in health and reducing weight go a long way in preventing morbidity and mortality, which is seen to exist with obesity. Uh, this was my last slide. Thank you very much for the patience.
Thank you, Dr. Dheeraj, for the wonderful talk. It was really a wonderful talk and very comprehensive talk. So I would request everybody to unmute themselves, and if they have any questions, they can ask Dr. Dheeraj directly.
Dr. Dheeraj, you explained everything very well. Nowadays, the people are talking about the gut microbiota. They say everything is related with the gut microbiota. If you are having a very good microbiota, chances of obesity is less, chances of diabetes is less, chances of cancer is less. So we know that microbiota is genetically determined, environmentally also, whether it is cesarean born, it is vaginal delivered. How you can modify your microbiota? Is there any way to reduce obesity by doing some research on microbiota? There's so much research going on, the fecal transplant and so many things. The so much you can say the billions of dollars are invested for the different type of probiotics. What is your take home on that?
Thank you so much for that nice question, sir. So you know what, diabetes, we are moving from pancreas to the GI tract. There is one very known figure who says that that diabetes is a liver disease. It's not a pancreas disease. Now we are moving to the intestine. Well, so yes, it is a known fact. But before fecal transplantation, there are certain things that we can do. Number one, obesity, microbiota obesity. It's a vicious cycle. So, gut microbiota begets obesity, and obesity begets the bad microbes. So, what you can actually do is we can go the reverse cascade. That is one, lose weight. That is one. Second, high trans fat foods are known to increase the bad microbes. Third, the artificial sweeteners also, particularly aspartame, may have a role in increasing the bad gut. And most importantly, acarbose is a drug which influences the gut microbes, getting the good ones into the bad. So, as regards to the good bad are concerned, I'm sorry, the names are tongue twisters. So I speak generally about the good microbes. That acarbose is one drug which reduces the bad microbes, increases, and of course, you talked about the fecal transplantation.
Thank you, sir.
Any other question? Sir, one question from my side. How to address obesity besides lifestyle measures?
Sir, nothing complete. I will tell you that we have drugs now. We have gliflozins, we have GLP-1s, we have tirzepatide coming soon. We have the higher dose 2.4 mg semaglutide. I won't mention the brand name, sir. We are fine with that. बट सर थोड़ा सा हंसी मिले इस चीज को कि ये जो चीजें है ना, जो गैस्ट्रिक बाईपास है, वो चीजें वो है, कोई बच्चा बोल रहा है शरारती के भगवान इस बार पास करा दो, अगली बार पढ़ लूंगा. तो पढ़ाई तो करनी पड़ेगी सर. कहने का मतलब ये है कि ये चीजें एक बार वेट लॉस करा देंगी, पर अल्टीमेटली डाइट एक्सरसाइज तो करना ही पड़ेगा. सो अपार्ट फ्रॉम डाइट एक्सरसाइज, यस, you have these various drugs, you have metabolic procedures. Also, meditation by reducing stress will reduce the need for the junk food, because as I said in my talk, that tasty food are the very good stress busters. So diet, exercise, meditation, and certain drugs, and of course, if nothing works, then metabolic surgery. The sleeve gastrectomy would cause lesser weight loss as compared to bypass procedure, but then there would be lesser nutrient deficiencies with a sleeve procedure as compared to the bypass.
And what about the psychosocial aspect of obesity?
As I said, that anything which would reduce the stress. And one very common thing, sir, that we often forget, is that eat at time, have dinner together, and eat slowly. These three maneuvers also can reduce. And I'm speaking my heart out. I'm not here to defend certain habits, but let us look at the olden times, sir. They used to have meals together, and in some parts of the country at night time they used to go for a stroll to have pan. Now, pan ka aap samjho significance, sir. It is not a good habit at all, but sir, पान लीव्स अ वेरी गुड टेस्ट इन माय माउथ. सो जब आप पान खाने जा रहे हो, एक तो आपकी वॉक हो रही है, दूसरा उस पान के बाद आप रात में कुछ नहीं खाओगे. ये स्विगी और जोमेटो जो है ना आजकल, इससे बहुत नाश पीटा हुआ है. सो दीज movers, sir, can also go a long way. And if you see, our ancestors were not as obese because they used to, and subha bhi टहलते the. They never jogging. So first of all, you should do exercises which are doable every day and any time of the day. That is one. And second, the diet control, psychosocial, as you talked about, and a closely knit family, eat together, eat slowly, eat on time.
Any role of intermittent fasting?
Sir, intermittent fasting, well, we wish to believe it were true, but there is data that intermittent fasting may not be as good as it sounds. And taking a step further, keto diet, well, they are the most useless thing. We have seen people lose weight, but in the process develop high LDL and end up with a coronary event. So you are starving, you are struggling, and reaching where would you have reached with obesity only. So keto diets should be strongly discouraged. Intermittent fasting, well, not as much of benefit as we have been told by the no lip service and hearsay advice. I was listening to a talk by Dr. Anup Mishra, and he obviously was not a very big proponent of intermittent fasting.
Dr. Dheeraj, what should be the essential component during a counseling, especially in a OPD of a practitioner regarding the obesity? Second thing, recently government has collecting the data for the hypertension as well as for the diabetes also, not for this thing. So how the association should approach to the government, specifically as far as the obesity is concerned?
First of all, the first question first. Anyone who comes to the OPD, obesity or fatness is the last word you use. That really amounts to body shaming, and what will happen then is that the patient will become resistant. He'll howl. Particularly if it's a youngster, they'll either howl at you or shout at you. So you have to tell it very discreetly that your physique is not what it should be of your age, and then you should say that this you can do to lose weight. At the same time, you should say that, well, I know you are a human, so maybe not every day, but maybe once in 2 weeks you are allowed outside. But then even on that day, you should eat with your conscience, not because Dr. Kapoor has said you will eat everything on that day. No, you have to eat with conscience for the taste's sake. In the ladies or the elderly gentlemen who are obese, what my favorite thing is that if you have, so they say prasad to khayenge. So my thing is that eat prasad as a prasad, not as a sweet dish. Now, as regards the government, well, of course, our respected PM has said obesity is a menace. Therefore, the message has reached them loud and clear. But obesity is not only a disease, but it's a mother of all the diseases. So if you nip it in the bud, possibly that could be one. But I think what should be done by the government? I think Respected Prime Minister ji is already aware of it. He said this in his Man Ki Baat. So not much to do there. They are aware, but the patient body shaming and scaring the patient. कि अगर नहीं खाओगे तो सर्जरी होगी. That is the last thing you do, sir. It should be encouraging, and you should suggest tasty options. For example, when you munch something with your tea, munching is eating something noisily. So that munching could be a namkeen also, a makhana also. So you you should you should give you should give a healthy munching option to the patient or the child, and obviously go tastier options. Pizza, for example, thin crust, brown base. So these modifications can be made.
Especially, sir, nowadays what we are seeing the physical activities in the schools. It is because of lack of the infrastructure or because of lack of the time. They had gone down. So the youngsters, especially teenagers, they are not very much physically active, and sports has taken a back seat in this era of competitiveness and the professional courses. So that is one thing I think we must try to do it, and how we can improve it uh, at the individual level, at the society level, at the association level. What the message we should give to them individually as well as to the society.
So you're very correct. I have tried this and failed. I once I tell the child, go outdoors, swim, cycle. Before the child, the parent speaks out. सर 11वीं में है जेई देना है वो तो पॉसिबल नहीं हो पाएगा as blunt as that. So I have tried that, and that is why I did not mention that, sir, because there are some things which are not doable. It will only be an eyewash. मतलब बच्चे से पहले पिताजी बोलते हैं कि साहब वो पॉसिबल नहीं है और कुछ बताओ. So yes, but at the level of societies and associations, but the fact is कि जो बच्चा हमारे पास दिखाने आ रहा है वही तो है जो रह सोसाइटी रह रहा है. तो अगर हमारे कहने से वो नहीं मान रहे तो कैसे मानेंगे. मतलब there is no harm in trying, sir, but to be honest, I have tried this and always got a negative reply from the guardian, sir. Always.
सर बेसिकली जो हम बोलते हैं कि ओबेसिटी को कि ये हेल्दी है, तो सबसे पहले तो हमें सोसाइटी में ये कंसेप्ट डेवलप करना पड़ेगा कि ये हेल्दी नहीं है, ये अनहेल्दी है. और उसके लिए जैसे आईएमए टाइप की जो हमारी बॉडीज़ हैं, एसोसिएशंस हैं, वेरियस साइंटिफिक एसोसिएशंस, तो उसका ही हमारा ही रोल है कि हम सोसाइटी में ये मैसेज परकोलेट करें कि ओबेसिटी इज़ नॉट ए हेल्दी थिंग. Your child is not healthy, you are not healthy, rather you are unhealthy and you are obese. And we have to percolate the message also that obesity is the mother of many diseases, like we have discussed today. So we can create certain posters and we can create certain awarenesses. And like Dr. Dheeraj has taken today's topic, I would request Dr. Dheeraj also to make a 2 minutes or 1.5 minutes video on obesity, whereby we can circulate in the public such topics. And it should be in Hindi and English mix. It should be in English so that it can go deep and wide into the circulation, and we can definitely make our public aware that what is obesity and what are the dangers with the obesity. So I think that would be a prudent step on the level of association, and the experts like Dr. Dheeraj can do this service to the society.
Sure, sir. Sure.
Yeah, definitely, Dr. Dheeraj. I would also request you to make a small video, as Dr. Pawan has mentioned, probably some 90 seconds to 2 minutes. And please give us this thing write up also of your talk so that we can include in our medical journal also. But your talk is very enlightening and very concise and very informative. And in a very brief time, you have really stimulated us, all of us. Thank you very much. Thank you very
sir.
much.
Thank you, sir.
And I would request all the participants to please percolate this message with your colleagues that we are holding this meeting every Thursday, 8:30 to 9:30. And uh, by increasing the participation, it will not only encourage our efforts, but it will also encourage our speakers, because it involves a lot of hard work from the speakers to present in such an august gathering. So it would be rather more prudent if we can percolate this message with our colleagues at the local level, so that we can increase our attendance in these meetings. Definitely, these meetings are going to be very informative and enlightening to all of us. And now I would request Dr. Mohan Rastogi, who's chairman of IMS CGP, to post a message of thanks to the speaker, all the delegates, and the dignitaries. Dr.
Yeah, good evening, all. Thank you, Dr. Dheeraj Kapoor, for a very nice and elaborative talk on obesity for all the IMA member of Haryana. And it really is, again, a torch-bearing talk, and I would say, to awaken us. And thank you for Dr. Pawan Goyal for all this effort. And of course, Dr. Kavita Yadav and Dr. P.JAIN for this nice initiative. But again, yes, I would again, stress upon this, that every one of us, spread this word that this kind of the talk is being held, and the participation must increase on this podium. Thank you very much.
Thank you, everyone. Good night.
Good night, everybody. Thank you so much for your active
Good night, sir.
participation. Thank
Good
you.
night, sir.
Thank you, sir. Thank you.
Thank you, Dr. Kavita. Thank you very much.
Next
Thank you,
week
sir.
is Holi
Night.
on 14th. So on 13th, we are celebrating Holi with a Kavi Sammelan on this platform only. So I would request everybody to join in for our Holi celebration on 13th with a Kavi Sammelan on this platform. Thank you very much and good night, everybody.
Sure,
Thank
sir. Thank
Good
you.
night. Good night.
Night.